Thank you all for inviting me. It's always a pleasure to touch base with ovarian cancer survivors and people who are dedicating their time, efforts to bringing greater awareness, funding research, and basically helping us advance the field for ovarian cancer. I'm sure that none of us sitting here in the audience are happy with the status quo, and we always think that there's more that can be done. So in that vein, I'm hoping that my talk can bring a little bit of hope in terms of, as Stephanie was mentioning, how things in treatment of ovarian cancer are changing literally weekly and monthly. These are my disclosures, funding for research from the companies listed here. Now, as I mentioned, immunotherapy is sort of a topic that many of you may have already heard about. In 2013, it was declared as the scientific advance for the year. But you don't have to go looking in scientific journals to see this. This is the title of a 2012 article in New Yorker, The T-Cell Army, which refers to the killer cells within our immune system. This is a picture of Jim Allison, who's the chair of immunology at MD Anderson, and he was named the Lasker Award winner this past year. As many of you may be aware, Lasker Award is thought to be the preamble to a Nobel. And the reason for this is discoveries within immunotherapy that have made revolutionary changes in melanoma and now many other cancers. But I would be remiss to come to New York and talk about immunotherapy without talking about this gentleman. And this is Dr. William Coley, who is sometimes termed as the father of cancer immunotherapy. Dr. Coley was a surgeon at New York Hospital in the 1890s in New York, and he had a patient named Elizabeth Daschle who sought care with him because Ms. Daschle had been a passenger in a train and her hand was caught between seats of the train, and so she developed a red, sore hand. And so she sought care with Dr. Coley, who first thought that she might have an infection. And so he went to do an incision and drainage of Ms. Daschle's hand, only to find that he didn't really get any pus back. And subsequently, biopsies showed that this young person had a rare form of cancer called a sarcoma, an osteosarcoma. And you have to remember that the surgeon was only in his 20s, the patient was in her 17, and despite the best available care back in the time, which was amputation of the patient's arm below the elbow, she rapidly developed metastatic disease involving lymph nodes in her arm, neck, and abdomen, and about 6 months later succumbed to her disease. This left such an impression on Dr. Coley that he decided to go back and review all of the hospital's records to see if anybody with this type of sarcoma had a positive outcome. And he did, in fact, identify an individual named Fred Stein, who seemed to have just as bad a disease as Bessie Daschle, but he walked out of the hospital without any cancer. And one of the notable events was that this gentleman, Mr. Stein, had developed a serious infection of his limb and his face. And you got to remember that this is back in the days where antibiotics were not discovered. So if you developed an infection, you basically had to just rely on your body's immune system to take care of it. And so Dr. Coley hypothesized that this infection must have had something to do with the regression of the cancer. And he was able to identify other individuals who had these rare cures from cancers that should by all rights have been terminal. And so he started to experiment with getting extracts from bacteria and actually injecting them into tumors. And that was sort of the beginning of immunotherapy. Now, this might have all been forgotten if it were not for Dr. Coley's daughter, who sort of rejuvenated her father's legacy, got a small donation from Cancer Research Institute of New York, and went on to basically make sure that the findings of her father's experiments were not forgotten. Around the same time, there was discovery of radiation and chemotherapy, two other important weapons in cancer therapy. And so those modalities seem to work much more reproducibly, and Dr. Coley's work was forgotten, though intuitively it made a lot of sense that if we can turn the immune system against the cancer, wouldn't that be a better individualized way of fighting cancer? But until very recently, so over 100 years, that had not been possible. And I'm going to tell you the story of how that is becoming possible by talking about immunotherapy. So what is immunotherapy? Well, it's really a radical departure from other types of treating cancer. So with chemotherapy, we tackle cancer because cancer cells are more rapidly dividing than normal cells. With radiation, we induce DNA damage that is repaired by normal cells, but not by cancer cells. So we're attacking the cancer cells. But with immunotherapy, we're actually not addressing the cancer cells directly at all, rather trying to stimulate the body's immune system to attack the cancer cells. So we're indirectly fighting cancer. There's some other important differences between these ways of treating cancer. For example, we all sort of know from vaccinations during childhood or getting chicken pox, we know that sometimes when you develop immunity against a pathogen, immunity against a microbe or a virus, then you don't develop an infection in the future because of that, because every time your immune system comes into contact with that virus again, it has memory, it remembers how to attack and destroy those pathogens. So there's a potential for memory associated with immunotherapy. Along the same lines, there can be multiple treatments, whereas chemotherapy, due to its effects on bone marrow and other normal tissues, can cause cumulative toxicities in many cases. And it's not that immunotherapy doesn't have toxicity. I'm going to talk about the toxicities of immunotherapy in detail, but there are different types of toxicity than ones that many of you may be familiar with chemotherapy. So immunotherapy is kind of a generalized term. It's as if I kind of stand here and tell you I'm going to tell you about cancer therapy. Well, you know, there are many different types of cancer therapy, and just the same way there are many types of immunotherapy. I'm going to start talking about what's making headlines these days, and this is a class of immunotherapy called immune checkpoint inhibitors or immune checkpoint blockers. So I'm going to start with that and then tell you about some other types of immunotherapy. So what is an immune checkpoint and what's an immune checkpoint blocker? The immune system is such a potent system in the body that any time it gets activated to reduce the chances of collateral damage by the immune cells attacking normal cells, the body immediately turns on a negative feedback system to, as soon as the immune system is getting activated, it also shuts it down along the same lines. These negative feedback systems are called checkpoints or immune checkpoints. And so naturally, immune checkpoint blockers are medications that block these negative feedback systems, in effect taking the brakes off of the immune system. So you may hear that terminology of taking the brakes off immune system. That's a actually relatively accurate way of thinking about this class of drugs. Now, I won't get into too much technical detail, but two of these brakes are called CTLA-4. So one of them is called CTLA-4. The other one is called PD-1. And PD-1 system, that brake system, gets engaged when the PD-1 ligand or PD-L1 binds to its receptor PD-1. CTLA-4 has also a receptor called or a ligand called B7 that binds to it. But these two braking mechanisms have been the center of some of the new drugs that have become available for immunotherapy. I like to show this graph, not to, again, get too technical, but here the y-axis shows percentage of patients surviving. And if you look at 15 or 16 months, the x-axis is duration of survival. You can see how treatment of melanoma has changed. So melanoma, as many of you may know, is a dangerous type of skin cancer. And until just 5 or 6 years ago, there were very few treatments that worked at all. This graph, the blue line, shows the standard treatment for melanoma, which is a type of chemotherapy called dacarbazine. And if you look at 15 months, only about 20% of patients who were getting the standard chemotherapy were alive by 20 months, compared to about 75% of patients that were receiving one of these checkpoint inhibitor drugs called nivolumab. This is a drug that blocks that PD-1 braking mechanism that I mentioned in the last slide. Many of you may have also heard that former President Jimmy Carter had melanoma with brain metastases, so that spread of cancer to the brain, and he was recently declared cancer-free after being treated by, again, one of these anti-PD-1 drugs. So there's definitely examples in the lay press or friends and family that you may have had, especially ones with melanoma, because many of these drugs were first treated in melanoma, probably because that is a cancer where chemotherapy has really never shown much of an effect. But what about ovarian cancer? So we're all here because we care about ovarian cancer. And recently there was a publication, a small set of patients, about 30 or so, and these patients were treated with nivolumab. Again, this is one of these drugs that blocks this PD-1 braking mechanism on the immune system. And this graph shows either increase in the tumor, so those are bars that are going up, or decrease in tumor, so those are bars that are pointing downwards in the patients on this study. Now you can see on the right-hand side of the graph, the CR stands for complete response. So 2 of the patients in this study were able to sort of have all of their cancer disappear. One additional patient had a partial response, meaning shrinkage of tumor. And then several patients, the SD stands for stable disease. So these were patients whose change in tumor size did not really meet the criteria that we would use to describe response. But it also didn't grow, and they did not progress. This is a picture from the publication where you can see the areas that are circled on the CAT scan picture are areas of disease, and you can see on the left-hand side before treatment, and on the right-hand side showing the complete response. The graph to the right is the CA-125 tumor marker, and you can see that that corresponded to the disappearance of disease on the CAT scan. Now, since that publication, there have been some other preliminary results that were available as abstracts and presented in the American Society of Clinical Oncology meeting last year. This is a meeting that happens in June, so this is from June of last year. And this is another drug that's an antibody targeting PD-L1, again, the PD-1, PD-L1 braking pathway. And this is sort of the summary of the responses that they saw. So about 10%, 11% of patients had a partial response. Another large group of patients, about 44% of patients had stable disease, meaning tumor did not shrink, but it also didn't grow. And so they concluded that the disease control rate, if we take the responses and we add it to the stable disease, was as much as 54%. Here's another study, so a different drug, different PD-1 targeting antibody called pembrolizumab. In this study, they sort of limited their patient population to those whose tumors expressed PD-L1, as a marker for whether this PD-1 pathway might be relevant to their tumor. And again, this is a table of the summary of the results. You can see that in this study, there was one complete responder whose all the evidence of tumor went away. Another couple of patients had partial responses, and once again, about a quarter of the patients had stable disease. So, in summary, sort of the early evidence for checkpoint inhibitor drugs in ovarian cancer is that about 10 to 15% of patients have objective responses, and then another 20 to 45% of patients may derive benefit in the form of stable disease, so not shrinkage of tumor, but stable disease. I didn't really go into the toxicities of each of those studies, but suffice it to say that there is toxicity, and I'm going to talk to you about that in the next slide. But these toxicities are lower for the PD-1 class of checkpoint inhibitors compared to the CTLA-4 class of checkpoint inhibitors. Those drugs have more frequent and more severe side effects. So this is kind of a cartoon of the body. I don't know if you can see all the text, but basically, because we're taking the brakes off of the immune system, we are non-specifically activating the immune cells, not just against the cancer, but against many normal tissues potentially as well. So the side effects of this class of drugs tend to be inflammation or immune sort of attacking of body's normal cells. These may include the gastrointestinal system, causing diarrhea. These may include the lining of the lung, causing pneumonitis or a pneumonia-like picture. These may also include attacking of hormone-producing tissues, such as the thyroid gland or even the pituitary gland in the brain, causing hormonal imbalances. There have been patients that in the early days of these treatments that have actually died due to treatment-related complications. So I say all of this because I don't want to impart sort of a sense of, oh, this is your own immune system, so it's somehow less side effects or easier to take than chemotherapy. And it's important to understand and recognize the potential side effects. But now, as we understand these side effects more, we're getting better at dealing with the side effects and with early recognition and treatment of patients with drugs that turn down the immune system, such as steroids. This is just a graph from one of these trials where patients were either given anti-PD-1 therapy with nivolumab, anti-CTLA-4 treatment with ipilimumab, or the combination of the two. And you can see that in the combination group, if you look under grade 3 or 4 toxicity, these are severe toxicities requiring frequently hospitalization. 2/3 of patients had this class of toxicity. Now, if you look at the bottom row, that sort of describes how often these toxicities led to discontinuation of treatment. And you can see that in the combination group in particular, about 1/3 of the time, treatment had to be stopped because of these toxicities. Again, trying to give you a realistic view that these treatments definitely hold promise, but they also have side effects. This is kind of a illustrative graph of toxicity and time on therapy. And you can see that there's different timelines for different types of toxicity. The red line there is the rash. which is the most common toxicity. That usually happens between 2 and 4 weeks and peaks about 6 weeks, whereas diarrhea or liver toxicity tend to be a little bit later and sort of peak at 8 to 10 weeks. Sorry, going the other way. Now, this is kind of a busy slide, but I'm only putting it up there to tell you that I told you about 2 pathways. I told you about PD-1 and CTLA-4. All of the molecules that you see on the left-hand side are ways of actually pressing down the gas pedal on the immune cells. And all the pathways on the right side of the graph are other pathways of taking the brakes off. So while we've made headway and proven that this type of treatment can benefit many different kinds of cancers, there are many other regulatory switches on the immune cells, and there are many drugs that are coming targeting each one of these stimulatory or inhibitory pathways. And so I think the name of the game moving forward is going to be combination immunotherapy and better understanding what pathways might be relevant for different kinds of cancers, because of course not all cancers are melanoma. So that was immune checkpoint blockade. I'm going to tell you a little bit about a different type of immunotherapy called adoptive cell transfer. Now, what do I mean when I say adoptive cell transfer? These are treatments in which the immune cells, usually T cells, which are sort of the killer cells of our immune system, are removed from the body. They're expanded in the lab, sometimes genetically modified, and then infused back into the patient. So this is a sort of an individualized type of therapy in which we harvest the immune cells, we either expand them or genetically modify them to make them more specific to the cancer, and then put them back in the patient. This is kind of a diagram of how this might happen. There are different types of adoptive cell therapy. In one type, the source of the immune cells are from the tumor tissues themselves. So a tumor biopsy is obtained. The immune cells that are within the tumor are harvested, selectively expanded several 100,000-fold, and then patients receive their own immune cells. And the idea here is these are the immune cells that made it to the tumor, so they must have recognized the tumor because that's where they resided and that's where they started from. Other types of adoptive cell therapy, we take naive immune cells, so just immune cells that are circulating in the bloodstream. They're genetically modified to be able to recognize a certain specific marker on the tumor. And then they're expanded and once again put back into the body. Before these adoptive cell therapies happen, before these immune cells that are expanded are returned to the body, usually patients receive a large dose of chemotherapy to kind of get rid of the body's non-specific immune cells, so that when we put these specific expanded immune cells, there's more room for them to take. So in this way, this is sort of like a mini bone marrow transplant for those of you who may have friends or family who have undergone that procedure. Now, this is a graph of different types of adoptive cell therapy in patients with melanoma. Each of the lines doesn't really matter. What I wanted to show this graph is if you look at the x-axis, that's survival in months. And you can see that with this type of therapy, about 20 to 30% of patients are long-term survivors in melanoma. And that's where these therapies have been used most frequently up till now. Now, studies in ovarian cancer are ongoing, and we don't have a lot of results on that. But I wanted to share with you one illustration of how this is impacting gynecologic cancers. And this is using those tumor-infiltrating lymphocytes, the lymphocytes that are harvested from fresh tumor biopsies that are then expanded and returned to the patient. And this is just a table showing two different patients who had metastatic cervix cancer after standard treatments and were able to have complete responses to this type of treatment that were lasting 22 months in one case and 15 months in another. There was another patient that had a partial response of lasting 3 months. So there is evidence that this type of treatment might be beneficial for gynecologic cancers, but its effect in ovarian cancer sort of still has to be proven. I'm going to just say a couple of words about different types of adoptive cell therapies. As I mentioned, one method of doing T-cell transfer is that the T-cells are genetically modified to recognize specific markers on tumor cells. And in this diagram, you can see that the left side and the middle side are schematic representations of how the specific part of the T cell that recognizes a protein on the surface of the cancer cell can be genetically modified to make it specific for that protein. These are some of the protein targets that for which engineered T-cell receptor or chimeric antigen receptors, which are the two types of these genetically modified T-cells, are sort of in preparation. The antigen or the protein that's expressed on the cancer cell are shown on the left column. Several of these antigens have relevance to gynecologic and specifically ovarian cancer, including the NYESO1 antigen, as well as the MAGE-A3 antigen. So these are, there are clinical trials for which ovarian cancers might be potential participants. And there is actually a recent phase 1 clinical trial in which the T cells are engineered to recognize part of the CA125 protein. So as almost all of you probably know, CA125 is a marker for ovarian cancer because ovarian cancer cells express this protein. And much of the protein sort of falls off of the cell, but there's a tail of the protein that stays on the surface of the cell, and these T cells are engineered to recognize that bit of CA125 molecule and use that to target it. And again, this is just a phase 1 study, so it remains to be seen whether it works. Lastly, I'm going to just say a brief word about vaccination strategies because there are some trials in this area. I'm going to share with you the results of a phase 2 study that was presented in Society of Gynecologic Oncology meeting, not this past year, but the year before, using a vaccine strategy that's called VIGIL. And this vaccine strategy basically involves taking a bit of ovarian cancer tumor at the time of initial surgery and then modifying the cancer cells so they can't grow anymore, but making them express proteins that stimulate the immune system so that then patients undergo regular chemotherapy, and after chemotherapy they were randomized to getting an injection of these modified ovarian cancer cells versus placebo. So the results of, and this is just a diagram to show the genetic modification of ovarian cancer cells. First, the cancer cells are radiated, so they can't reproduce anymore, and then they're genetically modified, so they express substances that, again, sort of stimulate the immune system. And sort of the preliminary results were that this vaccine is very well tolerated. Most of the side effects were injection site reaction, and these were mild in most cases. There were no severe side effects. And this is sort of progression-free survival curves, as you can see, the blue line and the red line do meet eventually, and the p-value there is 0.08. Usually for something to be statistically significant, we like the p-value to be less than 0.05, but there was a trend towards those patients that received the injection with this vaccine being disease-free longer than those who didn't. And so this was deemed promising enough that now there's a multi-institutional study, again, targeting patients that are undergoing initial treatment of ovarian cancer, because this vaccine requires cancer cells to be harvested at the time of initial surgery. So what are we trying to achieve here? Well, survival curves for ovarian cancer have sort of been pretty much where that light blue line is. With new immunotherapies in many cancers, including melanoma and lung, we are seeing survival curves more like the green line, where a small portion of patients are deriving long-term benefit. What we're hoping to achieve over the next few years by combining different types of treatment is to get a survival curve that looks like the red line. So we have a large portion of patients surviving a very long time. In the last couple of slides, I want to just tell you about some studies we're doing at my home institution, where we're trying to combine different sort of ongoing treatments with immunotherapy. In the first study, patients that are getting neoadjuvant chemotherapy, so patients that are deemed to benefit from chemotherapy first, are undergoing neoadjuvant chemotherapy with the standard drugs, which are carboplatin and Taxol, following by interval surgery. And then for the second part of chemotherapy, they're getting carboplatin, Taxol, and one of these anti-PD-1 drugs called pembrolizumab. And then they go on and receive the immunotherapy for up to 12 months after finishing the second part of the chemo. So that's one study that's about to open. And the second study, that's my study, that I'm hoping will open in the fall, it targets patients with recurrent drug-resistant ovarian cancer. And these patients are then randomized to either getting 2 of these checkpoint inhibitors versus 1 and then another one in a sequential fashion. Here the idea is we know the combination will likely have more side effects, but it may be more effective, but we're trying to test that versus getting 1 drug, and if there's progression, getting a second drug. And so we're hoping that that will open in the fall. With that, I appreciate your attention and look forward to talking to some of you and answering questions as part of the panel later this morning. Thank you.